All right, folks. Thanks for having me. First of all, Jeff and Berkeley, I want to give a quick shout out to them. This has been incredible. Honestly, like I go to a lot of medical conferences, and they're not as valuable or entertaining as what we've experienced this weekend. And being in person again, having that collegiality, seeing the smiles, the handshakes, the hugs even, has been really reinvigorating and really motivating to want to do more. So I just want to commend the organizers, Jeff and company. This has been awesome. So many of you might be asking, why is an ICU doctor coming to talk to you about metabolic health? And I must say, the story is a little bit, there's a bit of a story behind it, but first, I want to just make sure to disclose that I am a medical advisor for Edward Life Science. But my story really started with, my academic mission was always to look at how can we make our healthcare system more sustainable? How can we reduce our spending and at the same time provide better care for our patients? Because what was clear to me early on throughout my career is our system is super inefficient. And I can't say that strongly enough. And so we're always about being the change. Like, what can we do? So we set up a resource optimization network. This is back in 2015, 2016. A group of doctors, nurses, pharmacists, people with expertise in health economics, pharmacists. And we wanted to produce content, papers, peer-reviewed papers to say, hey, these are the ways that we could save healthcare dollars. And after doing years of producing papers, being as productive as possible, we really weren't seeing anything change within healthcare. So a group got together and how do we get the word out? And so we formulated this podcast, Solving Healthcare, and start to get some momentum. We start to get a little bit of attention locally, and then March 2020 happens. And many of you don't need me to say how much our world has changed since then. And as a frontline staff, as many of you have been a part of, which I want to commend you firsthand for stepping up, but I gotta say, this was a very challenging time. It was a very scary time as a clinician. So from a patient perspective, what we saw was tons of fear, tons of unknowns back in March 2020. I was there for our very first COVID patient at our hospital in the intensive care unit. And what we saw our patients go through was something that, I'm almost ashamed to say. The amount of the general fear, the fact that patients weren't able to see their families. We saw way too many people die alone. This was horrific. And from a clinician perspective, we were scared. We saw what was happening in Italy. We saw what was happening in New York. And we're asking ourselves, are we next? Is this it? Are we going to bring COVID to our families? Are we going to get sick? And we all had this huge incentive to do more. We wanted to be able to be there for our patients. We had that sense of duty that we needed to do everything in our power to get our patients and our teams through this. So as the weeks progress, we're not getting sick, we're able to protect ourselves. And then you start to see some common threads amongst our ICU patients that are landing from COVID. And, so we saw extreme age, we saw immunocompromised, so a poor immune system. But man, everybody had metabolic disease. Patients were, despite age, hypertension, diabetes, central obesity, metabolic syndrome. And the data was there to support that early on. Data coming out of China, 80 to 90% of the patients had metabolic syndrome. And what was striking was nobody was talking about it. Nobody was talking about it. And once again, well, I'm coming from a lens that we want to help. We want to help people get through this. And to me, for us not to be able to talk about this and bring this up was horrific. And to put it into context, like I know I'm talking about it early on, but I've been at this for 3 years, seeing critically ill COVID patients for 3 years. I still haven't taken care of somebody that's completely healthy. Literally, and there's going to be exceptions. You're going to find an intensivist somewhere that says they saw somebody healthy, but even if when you looked at the media, so in Canada I do a lot of mainstream media. So was giving weekly updates nationally about COVID, and you would hear on the news, we're seeing the 20-year-olds and the 30-year-olds admitted to ICU with COVID. But what they wouldn't tell you, so we took care of a few in Ottawa, and what they don't tell you was their average weight was well over 300 pounds. And if you're gonna sit there and tell me, as a healthcare provider, that's healthy, you got something coming to you. You know, like if you can't walk up a set of stairs, that's not healthy. And I don't care if you're not on any medications or what have you. And what I found frustrating was we were doing all, like as someone that was a bit connected to the media, it's like, let's get the word out. You know, we're going into like for example, late spring, early summer. Could you imagine if we were talking about collectively, pre-vaccine, what can we do to collectively as a society to get healthy? Getting outside, talking about what we eat, and then showing the value of it, especially with the amount of fear that was in the public at the time. And to me, it was such a missed opportunity. And but just it was to me, what was striking was how little people were willing to listen. So in terms of the pathophysiology, why do we see so much metabolic disease in the ICU? And to put it into context, with COVID, we're seeing 80 to 90% metabolic syndrome, but even on our common ICU patients, all comers, you're looking anywhere from 30 to 50%, depending on your population in the ICU. So what is it about that? So when patients have high levels of adipose tissue, visceral fat, as many of you know, it's pro-inflammatory. Your cytokines, IL-6, TNF, all are enhanced. You have more lipid deposition, you have more clot formation. And then using COVID as an example, you also have upregulation of our ACE2 receptors, which was what was believed to be the port of entry for how the COVID virus entered our system. And then we have the chronic inflammatory state, as we just talked about, and then the immune dysfunction associated with high insulin and leptin resistance. So when you add that all up, it's a recipe for severe disease. And to put the inflammation side into context, a lot of people don't, and maybe people know this, but it's worth mentioning. When people landed, especially pre-Omicron, I'm talking specifically, when they land in the intensive care unit from their COVID, they're not infectious most of the time. There's not. If you were to culture their virus or their viral load, you would probably not see much virus. But what drove them to being so sick is their inflammatory response. It's early on we were hearing about the cytokine storm. It was the pro-inflammatory state leading to the amount of inflammation in the lungs, was the clotting that we're seeing early on. So really, inflammation's a devil. And if you think about what lands people in acute care or intensive care unit, it's inflammation. It's when you think of a septic shock, it's your inflammatory response. When you think of ARDS, acute respiratory distress syndrome, it's your inflammatory response. So really, it comes down to inflammation. All right, so what do? We find out that we're seeing more metabolic disease. We want to do our best to get through these waves, but then we lock things down. I'll give a first pass to when we first went through the pandemic and not really knowing what we're doing in March, but I come from Ontario, which had the longest lockdowns in Canada. And when we decided to ignore this metabolic link, but then what happens when we lock down? We get people at home isolated, impacting their mental health. We're telling them to stay home, not move, not get outside, not get some vitamin D and some sunlight. And many of you have heard of the, I don't know, COVID-15 or COVID-20, the amount of people that put on that excess amount of weight. So we only made the, I saw somebody raise up their hand. I put on that 20. The issue only got worse. And then we closed down gyms. Instead of saying, hey, especially those that were, I mean, I don't want to get too off the rails here, but those were lowest risk. We're not letting them go to gyms and staying healthy. It was criminal. So once again, I come from a lens of we want to do our best for our patients. What can we do? And somebody throws me this book. Quadro, have you heard of this, the diabetes code? I'm like, I mean, Jason came on the show earlier on talking about intermittent fasting. I've been doing it for a while. And they point out the fact that you could reverse type 2 diabetes. I said, listen. I did internal medicine training. I've been a clinician since 2005. Stop talking this gibberish. And she's like, no, Quacho, like read it, and like even talk to Jason about it. And you dive into it, and I'm like, what the hell is this? Like, this actually is happening. We don't talk about this at all. Pull your family doctor, pull your internal medicine specialist, pull your endocrinologist, and see how many people talk about it. So my mind was blowing. I was like, this can't be true. So let's look at let's talk to some other cats. So we get, I'm sure Ken Berry's sleeping right now, but we get, you can see the recording, Ken. We get him on the show, and he's telling me he reversed metabolic, 400 patients of their diabetes. I was like, no, right? I got to talk to Rob Wolf, and he's telling me the benefits of these low-carb diets. Low-carb diets, people are reversing their metabolic disease. I was like, what? Talk to Vanessa Spina about ketogenic diets. And she tells me, you know, and ketogenic diets, I'm thinking like, I don't have any epileptic kids that I'm trying to treat. And she's saying, you are reversing metabolic disease in weeks through this format. I was like, weeks? What is happening? You talk to Brett Sher, and he's telling you about improving people's cardiovascular status, and my mind was blown. I'm like, I cannot believe we are not screaming this to the world right now. So this was a big driver for me. This is why I'm here. Started to cover this content on the show, started to reach out to as many people and say, let's increase the awareness. People don't know this stuff, right? And then I'm thinking, am I in a bubble? And in terms of this, seeing the links of metabolic disease and COVID outcomes. And here's a colleague of mine, Tom Saris, 30 pounds overweight, pre-diabetic. He's like, I'm seeing what's happening, and I'm gonna be the change. He went low carb, did intermittent fasting, and lost 30 pounds in a short period of time, keeping the weight off, seeing the benefits of being able to reverse metabolic disease. And one thing I can't understate enough is, you know, we talked about the pain of seeing people go through COVID, going to the hospital with COVID, but coming to the ICU, like by the time you see me or any of my colleagues, like your life has changed completely. Like you are not gonna be the same. This is the reality of landing in acute care. And to give you some context, we talked about, you know, being away from family and so forth, but you land in a hospital in ICU for whatever reason, you can't communicate. If you're in pain, it's hard to articulate. even something as simple as wanting to scratch your head, we tie your hands down because we don't want you to reach for the tubes. You're poked, you're prodded. And so when it came to COVID, about 30% of our patients passed away. When it comes to any typical ICU patient, we're looking at a mortality of 15 to 20%. So then, even if you survive, your life is not the same. The mental health side, there's tons of PTSD, depression, anxiety related to your experience in the intensive care unit. But functionally, the stuff that you love to do, whether you were a golfer, whether you were a hiker, too many of our patients don't get to achieve their goals, right? So once again, more ammo to say, what can we do to prevent you from landing in an ICU, prevent you from being acutely ill? So we're gonna do a little bit of quiz. So as I said, my research passion is in reducing spending. So these are Canadian dollars, which is about, $1 to $300 ratio at this time. I had to divest a lot of money to get here, but just joking. So and these numbers are parallel to US dollars, or to US spending. So we're gonna do it by raising your hands. What's the average ICU cost per day? A, $3,500. B, $1,500. C, $2,000. Oh, biters. D, $5,000. So it's probably in the US, it's closer to 5,000, but the answer is A. It's about 3,500 a day. But the most expensive day typically is day one, which is about 8,500 because of all the investigations and so forth that are done that day. You guys are too good. Okay. Do we want to do this one? How much time do we have? Yeah, we'll roll. Average cost of a COVID ward patient. A, 8,500. That's a total cost too, by the way. B, 2,100, or 21,000, sorry. C, 12,000. D, 16,500. So the answer is B, 21,000. And once again, when we think about when we think about the roles of metabolic disease and the reversibility of this, we can't ignore it. Okay, last one. Average cost of a COVID ICU patient. So A, 62,000. Good. B, 35,000. C, 22,000. D, 52,000. Yeah, D is the correct answer. And why do I want to put these costs up here? Actually, I'll talk about that in a second. But to me, all this, seeing about the reversibility of metabolic disease, it was an aha moment for me. It was an aha moment saying, like, what we need to invest in, what we need to think about, is the prevention side. Let's put the resources into preventing people from landing in acute care. Prevention over prescription. That's where we're gonna put a dent in this thing. We talked about the cost related to this, but all the sacrifice people that will be, all the trouble our patients will go through, and their families. Like we don't often talk about the family side, where that spouse or that family member is no longer working as a result. They're no longer contributing to the workforce. There's economic implications for that. So that is amplified. So this was a big moment for me. This is where I said, our research group, this is where we got to focus. It's time to intervene. Resource optimization at work. Let's do this. So, and what I liked to leverage or like to get people to think about is what you could do if some of those funds were diverted into prevention. Like these are big dream aspirations of mine, but what would happen if you really made sure that your city was more walkable or really incentivized like getting people out? What if you subsidized gyms? What if you had better access to high quality food? What if you had access to nutritionists and people that could help guide you through improving your metabolic status? And this is an idea that actually I think is happening already. I would love for people to have some form of insurance rebate, tax rebate. You get your 10,000 steps five times a week, boom. We will reduce your insurance, we'll give you that tax rebate. Like, think outside the box, you know what I'm saying? I mentioned this already. The one thing, before doing this slide, I wish I would have found something on septic shock. So, formally, yeah, I mentioned in terms of the incidence of metabolic syndrome in the ICU ranging from 30% to 50%. But I suspect, at least from personal experience, when it came to patients that were coming in for septic shock reasons, almost like a significant amount of those patients are coming in with metabolic disease because of that, once again, being so pro-inflammatory. So as I've tried to illustrate, like, our group really wants to be the change. We want to say, what can we do to highlight some of these issues? I went on Diet Doctor 2+ years ago, and one of the questions that they left us with is, so what's next? You've been trying to increase awareness with metabolic disease and attempts to reverse it, and it was one of those things that he's like, yeah, it's a good point. Like, what are we doing next? And got our group together, and I'm so proud of this paper. They put together basically a position paper saying, like, is there a role for low carb diets in the intensive care unit? And this is a busy slide, I apologize, but is anyone out there, I know I just spoke to an ICU nurse, I said Dr. Schaefer in the mix too, so you're not allowed to answer, but do you have a sense of what we feed our ICU patients? Someone just piped out Glucerna was our lowest feed, but now there's Peptamen Intense, which is a little bit less glucose. But the short version is it's crap, right? It's very, like, so once again, when you open your eyes, you can't unsee this stuff. So when you think about, once again, you come into ICU, you're coming in with an inflammation process. So then you learn about low carb and stuff. So you look at the ingredients and the macros of what we're giving our patients, and it's the exact opposite of what would be ideal. You see, it's high glucose, seed oil, it's pro-inflammatory. And so we try and look at other alternatives. Is there ways of improving our feeds to see if we could get our patients in a better state? So one of the reasons we'd start to dive into this was, so most patients are being fed through their stomach, a tube that goes from your nose into your stomach, so enteral feeds. There's a version where it's given IV, we call it TPN, parenteral nutrition. There was a recent study looking at a lower carb parenteral nutrition, which illustrated lower infections, less time in the ICU, and is this being adopted globally in the intensive care unit? Absolutely not. So we really thought this was an opportunity to highlight why we could consider this. So there really isn't robust data to support, hey, we should be providing our patients with a low carb diet. But I think we've made the case that, is it worth doing an RCT to look at these things? Absolutely. Why not? Like, if you think about how we approach feeds too, like, we're getting continuous feeds, right? Like, there's no break. And you look at the glucose control in our patients. When we see the high levels of glucose and insulin, you're not healing. And there's patients, like, I left the ICU on Wednesday. We had a patient on 12 units an hour of insulin. An hour. Someone else could do the math, how much they're getting per day, right? And that's, once again, in continuous feeds, pro-inflammatory, and we wonder why they ain't healing. So last few things that I want to mention. One of the most, for me as a person of color that was dealing with patients during the pandemic, what was hard to see was often the hardest hit, the ones that were most impacted were people of color, people that were racialized, Black, Hispanic folks. And, you know, there's a lot of talk, especially early in the pandemic, is this genetic? Is it, you know, do they have low vitamin D because of the genes and so forth? And the more I look into this, it really came down to socioeconomics, to be honest with you. Like when you look at the pandemic as an example, everyone, you got to stay home, but who's not home? Who's the essential workers that are delivering the Ubers, that are in the long-term care, that are personal support workers, that are helping us get through this, and then unfortunately getting COVID, living in multi-generational homes, passing along to their families, not having time to, because of their socioeconomic status, not getting access to high-quality foods, not getting to gyms, because basically they have no time. And I think what it left me with is we need to always look at those that need us the most. We need to look at ways of trying to get to the people that have been impacted the most. So and I'm not one to like humble brag or whatever the expression is, but I'm really proud of our group about this. We got a $100,000 grant locally in Ottawa to try and be the change, to try and reach out into our Black communities in Ontario and provide a virtual model to reverse their metabolic disease. And ideally, we're looking to treat about 60 patients. But to put it in perspective, this grant to support all the allied health that's coming through, the research assistance, the publications, to be able to present this at some time, maybe at low carb, you know what I'm saying, was $100,000. That was if we prevented two COVID admissions to ICU, we're able to do something like this, right? So this is why I always like to think about that opportunity cost. Like if we can prevent less people from landing in an ICU, this is the magic that could happen. So I want to leave you guys feeling empowered. I want to leave you guys feeling motivated. You guys, I want y'all to continue to rise up. What we're doing here, everyone in this room has done a great job at increasing awareness of saying the impact of metabolic disease and how we could reverse it. And this is something I want us to continue to do. I always want to think, how do we make this knowledge accessible? We need to often think of creative ways to do that. It's not always conference format. It's not, maybe it is the podcast, maybe it is the infographics, maybe it is having more access to the amazing anecdotes that people have gone through to get through their metabolic disease. Like hearing Sean's talk yesterday and how many people have been in that database of 12,000 people. Like if I'm Sean, maybe he's doing this already, I'll put that out a daily tweet on like, here's a story about somebody's reversing metabolic disease and improving their autoimmune condition or what have you. Like thinking outside the box, being agile, knowing that, you know, the way we articulate, the way we communicate may change from day to day, but always thinking about how we could reach our people. And I know this might be tough to hear, but thinking about our hardest hit marginalized communities, like we are not doing a service if we're not hitting the people that are being impacted the most, right? And if you look at around the room, we have some incredible, thoughtful, genius folks, but are we reaching out to the people that need us the most? And I think I want you guys to leave here saying, with all that energy, with all those resources, how can I connect? How can I be more impactful for racialized communities, marginalized communities? Because this is a time. Like it really is a time. Like enough is enough, if you know what I mean. Last thing, Mickey was kind enough to give a plug for our Substack, and this is our attempt to be the change, to get the message out there, to let people know on ways they could get healthier, but not only ways to get healthier, but how we can, how the system could change, how we could really impact folks. Like we had an impromptu talk with Dr. Schaefer, and we were talking about our jobs. Like when we treat an ICU patient, I'm treating that one patient that's in front of me. But when we reach out through social media, through conferences like this, you can impact so many lives. And it's one of the most rewarding things that, like when you occasionally get that family member that says, you know, we saw that podcast of yours and now mom's off her diabetic meds, like that W feels good. I won't lie, like that's such a rewarding experience. So I wanted you guys to continue to hustle. If you're into it, quadcast.substack.com, that means the world to us. And thank you.